So thank you, Dr. McCullough. I'm Kimberly Milhoan, Dr. Kimberly Milhoan. My husband, Dr. Kirk Milhoan, has joined us. Dr. McCullough, the other Dr. Milhoan, Kirk, and I know Dr. McCullough through email, but we've never met face-to-face. So this is our first face-to-face introduction. So we thank you, Dr. McCullough, for your time. I kind of wanted to, as a way of introducing us to each other, and kind of, you may know the Pono Coalition for Informed Consent has hit the news in Maui and Hawaii, and I understand nationwide in the last week. So I kind of wanted to do a little introduction of us and how we came to be here, how you came to be a part, how I came to come across you, so how our collaboration started. So I'll kind of start quickly. I'm a pediatric cardiac anesthesiologist. Kirk is a pediatric cardiologist. We came to Maui 7 years ago when Calvary Chapel South Maui asked him to be the lead pastor of Calvary Chapel South Maui. We both have continued to practice. We have a nonprofit organization. We do international medical missions, taking care of kids with congenital heart disease. Kirk does locums, inpatient pediatric cardiology at a children's hospital in Texas. I still do locums work at children's hospitals in both Texas and Arkansas. I work locally, and Kirk and I have what's called a federally recognized free mobile medical clinic where people receive free care from us through this free medical clinic. So we've had that clinic since we came to Maui. Kirk, correct me if I'm getting facts wrong when we started it, but it was pretty, 2014 we came here, we opened the clinic. Our church, Calvary Chapel South Maui, has a food pantry. And so when the pandemic started, we were incredibly interested in keeping our volunteers safe, our clients safe. And so we transitioned and we're just an essential service to keep our food pantry open at the time that things were locked down. We weren't having regular services with the public. So Kirk and I, from the beginning, had this interest in keeping hundreds of people safe. That was our interest in doing lots of research about the pandemic, care, so forth. And as 2020 had it for lots of us, we had lots and lots of trips canceled. International medical mission trips canceled, vacations canceled, my locums, part of my locums opportunities canceled. So I had a lot of time at home to study a lot and inundated myself with materials. So I think I came across you because probably there was a response to a journal article that was, they were refusing to print the response to the journal article. I had read the journal article and I had read the response. I thought legitimate. Why aren't we publishing this? This is what physicians and scientists do. We discuss these things. We discuss the data. Why on earth would you not publish this? So I saw the petition for just asking that it be published. And then since I signed that petition, that's how I came into your orbit and got invited to be part of this email group that now there's 2 email groups, and you might want to explain that. And when I came across you, I should have looked up dates. I didn't, but when I came across you, my first reaction was, you have got to be kidding me. How come I haven't known about this information? Because what I'm telling you is I was scouring the information. Kirk and I kind of divvied up how we handled it because he's the pastor. People would bring him all the controversy videos, right? Pastor, what do you think of this? What do you think of that? And we're a resource to our congregation, to our friends, to our family. And I pretty much told everyone, I'm not looking at any of those things. I am only looking at medical literature. So we kind of divvied up the work. And so, I mean, Kirk can attest, I spent hours and hours and hours and hours mining the literature and reading things. And I've said this many times. I'm going to praise my husband. And he has a PhD in cardiac physiology and pharmacology. And then he's an MD, then he's a pediatric cardiologist. He's one of the smartest people I know. So if I come to him with anything that it doesn't make sense to him, I'll say, I'm concerned about this. I read this. If I can't explain it well to him, I got to go back to the drawing board. So I was immersed in this information. When I came across you, that was my reaction. Are you kidding me? How come I haven't known that this information is out there? So I saw your Senate testimony. I think that was your first public testimony. And then I saw your published work. So with that long introduction, I'm going to let you kind of catch us up on kind of the point at which I caught up with you and the work that you've done.
Well, thanks for having me. And that's a real testimony about how we're not meeting and interacting anymore. I think there previously, in my previous academic life, sometimes I would travel 200 segments a year, sometimes a dozen or more international trips. We used to interact all the time. The lifeblood of academic medicine is scientific interchange and discussing. No two doctors really agree on anything. Probably like no two lawyers agree on anything. But when COVID-19 hit, so many things changed. And one of the big things that changed is we quit talking to each other, and we ended up becoming islands. And then there was a corruption of clinical care and corruption of the medical literature, to the point where, you're right, it became impossible to find information about various things. And then it became memorialized in December with the Trusted News Initiative, which was overt. And it was stated that there is a plan, a major media and social media plan, to massively promote the vaccine, do anything to reduce vaccine hesitancy. And that means to squash any information on early treatment, to squash any information on vaccine safety, and railroad the vaccine. And it was overt. And so to this day, people are scrambling. My phone is lighting up every minute. People are scrambling for information on treatment. Where can I find monoclonal antibodies? Well, how can I get treatment? How can I get treatment? It's been a complete block on treatment. So
go ahead.
Well, no, just by way of introduction. So I'm Peter McCullough. I'm an internist and cardiologist. I went to Baylor undergrad. I'm wearing my shirt. Baylor is the national champs in basketball.
Kirk's giving you a sick'em over there.
A big sick'em, yeah, right. So Baylor's the largest Christian university in the United States. Was founded back when Texas was its own country, the Republic of Texas, for 10 years, and terrific place. It's 90 minutes south of me in Dallas. I see patients every day in my practice, or at least every week, and I have academic days. I'm the editor of two major journals, Reviews in Cardiovascular Medicine, Cardiorenal Medicine. I publish a chapter in Braunwald's textbook of cardiology for the last 25 years. Kirk would recognize it as kind of the Bible of adult cardiology. And I have over 650 publications in the peer-reviewed literature in PubMed. I published in New England Journal of Medicine, the top journals. So I'm kind of out there in the group of recognized doctors in the United States. And I started seeing something really go wrong with COVID-19. I saw things starting to break down, that patients weren't being cared for, publications weren't going through. There appeared to be this lack of focus on sick individuals, lack of focus on early treatment. Everything was going to promote fear, suffering, hospitalization, and death, and then promotion of the vaccine. That was very clearly a program. So I always have treated my high-risk patients using the precautionary principle. That is, using whatever I could to reduce hospitalization and death. And to this day, we haven't had a single leader in the world state the problem. The problem is COVID-19 in high-risk individuals can result in hospitalization and death. That's the problem. No one's actually stated the problem. To this day, they haven't stated the problem. And if they can't state the problem, they cannot find a solution. A solution is obviously to do something before the hospital to prevent hospitalization and death. I mean, everyone would agree with that. And doctors are confused. I had a conversation with a critical care doctor who finally wanted to talk to somebody about this. And I talked to him and I said, wouldn't you agree that we have to do something before the hospital to prevent a hospitalization? He kind of looked at me in a confused way. And it's amazing how doctors are just confused. They are confused. We have about, right now in the United States, we have about 500 doctors trying to treat the whole country right now who's following. And we got 1 million doctors and 500,000 doctors sitting on the sidelines, confused.
Correct.
They're fearful, they're confused, they are, I don't know, ashamed. That's how I would describe them. We got 500 doctors, including us.
So tell the story of the publication that was, I think it was it a preprint in April and then it was published in
So the story was early on, I applied for and I worked with the FDA over a weekend and got one of the first investigational drug applications for hydroxychloroquine, and communicated some with the Chinese early in March. Everybody went into lockdown and we closed down the heart catheterization laboratories. We closed it, and there were no patients. So we literally sat around with nothing to do a year ago in March. And so I said, listen, I will kind of pour myself into this. I have, I went to medical school at Southwestern. I went to my residency at University of Washington. At the time, it was top ranked medicine program in the country. Got my master's in public health at University of Michigan. Did my fellowship at Beaumont Hospital, now the Oakland University Beaumont School of Medicine. First paper I published was in the New England Journal of Medicine. And I've been acing it throughout my career. And I did not see anybody acing it on outpatient treatment of COVID-19. In fact, I didn't even hear anybody talk about it. Our task force calls were all about personal protective equipment, wearing masks, how do we protect ourselves? Then there was some discussion about putting people on the ventilator, but none of it was patient focused, none of it. Mm-hmm. And I said, that's crazy. So I organized teams. I started communicating. I had great collaborations in Italy. I was part of the Coracle network that were collecting data. And we basically, by June of last year, figured it out that we have to do something to reduce viral replication, something to treat inflammation or cytokine storm, and we have to do something for anticoagulation because people died of blood clots. When the O2 saturation was going down, that was actually blood clots. That was micro blood clots. The Italians showed it in the autopsies. To this day, when the O2 saturation goes down, doctors think remdesivir. It's like, no, that's too late for remdesivir. That's blood clotting. That's micro blood clotting. Every single autopsy has shown that. And it's just amazing how doctors to this day are confused about just fundamental principles. So we needed about 4 to 6 drugs to use in combination. We put together our paper. The title of it was The Pathophysiologic Rationale for the Early Ambulatory Treatment of COVID-19. And we use the precautionary principle, which basically says that it's a potentially fatal illness. We can't wait for large randomized trials. Sorry, can't wait for them. We're going to look for signals of benefit, acceptable safety, and put drugs in combination because it's a fatal viral illness. Single drug won't work. And so as the rest of the world was trying to wrestle with a single drug like hydroxychloroquine or something else, or remdesivir, we said, forget all that. We're going to just go with a drug combination. We published that in the American Journal of Medicine in August of 2020. It came out in print in January of 2021. But to this day, that paper is the most frequently downloaded and utilized paper in all of American Journal of Medicine for that year. So if that's any proxy for how important that was, and by the way, in June, when we submitted, there were 55,000 papers in the literature. Not a single one taught doctors what to do for COVID-19, not a one.
Yeah. So I had this conversation with a reporter yesterday, and I was talking about this. I was talking about off-label use of drugs and FDA approval of drugs. And what I was explaining is I'm an anesthesiologist. I do this in real time, meaning I have to understand pathophysiology and I have to understand pharmacology, and I have to see a problem in real time, think, what is the problem pathophysiologically? What do I have at my disposal pharmacologically? What can I give? Did that work? Did that not give? Did that work? Did that not work? Do I do something different? So I do that in real time in a anesthetic case. So when I found your paper, Pathophysiologic Rationale for Treatment, you're doing what I do in the operating room, you're doing on an outpatient basis. There's a pathophysiologic rationale, and then there's a pharmacologic rationale for using, and I love how you termed it, early outpatient I'm going to say it wrong, sequential multi-drug therapy.
Right. So that was the second paper. So before you knew it, we had monoclonal antibodies. We had enough data with ivermectin. We actually probably have enough data with fluvoxamine, although it did make the cut originally. So we published this second paper in Reviews in Cardiovascular Medicine. By that time, the literature was locked down. And so fortunately, I'm the editor of a major journal. I commissioned a supplement, COVID-19 supplement, second separate special issue editor, high quality peer review process. And that was published in Reviews in Cardiovascular Medicine with the updated protocol. And now that is the most frequently downloaded and widely utilized protocol in the world and paper in the world right now. And so it goes to show you, those are the only 2 papers. Now, what had happened is, to give everybody credit, people were inventive. Didier Rialt and Matthew Milhoan and Dr. Lagier in France were working with hydroxychloroquine and azithromycin. Vladimir Zelenko in Monroe, New York, different combinations. Brian Proctor here in Dallas, different combinations. Yvette Lozano, who probably was ahead of anybody. Yvette Lozano was working way back in March. She called the White House and said, listen, I think I'm onto something. We can treat COVID-19. All these people were innovators, George Fareed and Brian Tyson, Central California. And so what had happened, by the second paper, we started communicating. I said, listen, there's so much innovation here. We have 57 authors of people who were trying different things. Zelenko was our anchor because I give him credit. He was one of the first innovators. And so we had a broad author base, and we published the second paper, including monoclonal antibodies, which we feature. And monoclonal antibodies fully FDA, EUA approved. You mentioned labels, which is interesting. Labels are advertising labels. They are advertising. They're advertising documents. No one's going to have an advertising label for a drug repurposed for this condition. That's not going to happen. So there will never be any labels for this condition. In fact, there's no labels for the EUA drugs because they're not marketed products. So there are no labels. And there's a great paper, a great analysis by Jane Orient from AAPS that said in cardiology, which is correct, I think there's only 6% of our clinical work can be directly guided by guidelines, 6%. And 94% takes some judgment. Something is always a little different than the guidelines. And in medicine is an art and a science. And when Senator Johnson invited me to the Senate, he told the story. We were in his Senate chambers. He said, listen, my daughter has, she had congenital heart disease, and the doctors had to do 2 surgeries, and he was explaining what was going on. He goes, listen, these doctors in the OR, they didn't sit and say, oh, is there a randomized trial for us to kind of do the intra-atrial baffle this way? They said, forget it. They used their judgment and they did the operation on the child and saved the child's life. And Senator Johnson, out of all of them, said, listen, he goes, I know your doctors. He goes, I'm just asking for your judgment. He said, doctors are behaving like they can't treat this problem. He goes, I've never seen anything like it in my life. And I said, I know. I think doctors initially, and this is what I told Tucker Carlson, he goes, how did this happen? I said, I think it was fear. I think for the first time, doctors were terrified of the virus themselves. They were terrified in coming into contact with patients, absolutely mortified.
And they still are, actually.
They still are. It was the most convenient thing in the world for a practice to say, you know what, we don't treat COVID. Go to somebody else. And you say, well, who should I go to? I don't know. We don't treat it. And to this day, even our major medical centers, Harvard, Johns Hopkins, man, they don't treat COVID. Now, they'll admit an inpatient if they have to, but they don't. In fact, the COVID census, by the way, if you ever sit on one of these meetings, the COVID census is a negative thing. Oh, we've got 150 COVID patients. Oh, yeah. That's a negative thing.
Yeah.
Since when is a medical problem a negative thing? They're getting fully reimbursed for it. Since when is that a negative thing? Is the number of bypass surgeries we do a negative thing?
Peter, I wanted to just share with you, I just came from a person's house who I caught them late. I caught them at about day 8. You could tell it was already happening. I tried anticoagulation. I tried some steroids, but the SATs just progressively went down. He went to the hospital, got to the point of BiPAP, came home about 3 weeks later. But he has come home, was given oxygen and incentive spirometry. No medications, no guidelines, and no doctor will see him.
Yep.
He doesn't know how he's doing. I went to his house. I evaluated him, did all the things a doctor would do: see the patient, touch the patient, examine the patient, do basic vitals, including his pulse oximetry. Because you know what? They had no idea what to do. This idea that we're sending patients either before with just an initial positive test, go home, call us when you're really bad. They thought they were really bad. Or when we send them home, we're still sending them home really like, well, we don't want to see you. Make sure you don't come to us too soon. And this guy is still on home oxygen with a significant pneumonitis with no plan.
And I tell you, there is a real theme in COVID-19. It's called penalize and blame the victim.
Mhm,
So it's the
mhm.
COVID-19 victim, and they're even vaccinated or unvaccinated, and people kind of say the words with vitriol, and their census of COVID patients is a vitriolic report, and they despise these COVID patients. They don't see them in the hospital because they don't have to, because they're in isolation. And then there's no follow-up. I saw a nun on Monday of this week, nun, she's in a wheelchair. She was on a ventilator for like a month at the medical school, UT Southwestern, no follow-up, just like, get out of here. And the poor thing's on an oxygen concentrator, and she can't breathe. Her lung exam was terrible. She was getting no care. We had somebody in our circles in our church, a young man who got COVID, didn't get hardly any care, had chest pain, desaturations, went to urgent care a couple of times, got like a Z-Pak, didn't get better, went back, finally got a CT, he's got a PE, 3 weeks after. So the theme of COVID care from the beginning to the hospitalization and the post-hospital phase is horrendous. It is absolutely horrendous. In fact, it's all wrong. Every single step is wrong, and I couldn't stand for it. And that's the reason why I stepped up with these publications. And the letters to the editor I got for the American Journal of Medicine were very interesting. I got 6 of them, and they came in from Duke University, Monash, McGill, universities down in Sao Paulo. And the general theme of the letter was, Dr. McCullough, you can't do this. You can't treat COVID-19 patients. And I'd respond, yes, I can. And there's even more data, and overcome your fear and join me in treating COVID-19 patients, or overcome your therapeutic nihilism. They kept sending these letters. They kept giving me more chances. And then even on one of them, I said, listen, I even have an updated protocol, so it's even more. And so then they would try to nitpick a drug. Well, you can't use hydroxychloroquine. I said, well, even have more data. Here we go. Now we're just buried in data. So when people say, hydroxychloroquine doesn't work, I said, well, we got 250 supportive studies now. Which one do you want to start with? Oh, well, and then they just whimper away. So the doctors who don't treat COVID-19 patients, they can't look us in the eyes. They look like they're in a trance. They just kind of have a glaze in their eyes. They look fearful. They look timid. They look ashamed. And they're the same doctors who just have this unbridled, relentless, vicious attack with the vaccine. It's the same doctors, and it's just that binary thing. It's the binary thing. Take the vaccine and die for all I care, but take the vaccine. It's the same doctors.
So I want to kind of go back in time, because what you said, people ask you, how did this happen? Right? Like, we are in the minority of physicians with this viewpoint. And I will have friends and family ask me that question. How on earth are you guys in a different viewpoint and you're not in lockstep with almost the entire medical community? And one of my answers, you're right, is fear. But so Kirk and I were motivated by the fact that we had a food pantry. We had hundreds of people to protect. So we didn't have the option to just go home to our house and take care of our family. And I think a lot of people, they had that option. I'll just go home to my house and I'll take care of my family. And I don't have to take care of hundreds of people. And so we were taking care of hundreds of people, and then I like to use the verse that Jesus talks about. He had compassion for them. They were distressed and dispirited like sheep without a shepherd. There's all these people, they can't get access to a physician to answer their questions. That's why Kirk's, what do you think of this? What do you think of this? What do you think of this? I'm exploring the medical literature. People send me things. What do you think of this? What do you think of this? So everyone in our orbit knows they can come to us and ask us questions, and we'll try to help them interpret. So that's I wanted to tell the story of how the Pono Coalition came to be. That's exactly what happened. I lead a women's Bible study every week. Someone in my women's Bible study is on the beach. She's talking about it. Someone overhears her and says, I've been dying to talk to some doctors. You know some doctors? Sure. I talked to her on the phone. We meet for coffee. She's friends with, now we get to the public health, the public news in Maui and Hawaii right now. She's friends with Dr. Lauren Pang, who's the Maui public health officer. They've known each other since 2014. He worked on a GMO moratorium initiative with her and Bruce and Sacha Douglas, who are co-founders of the coalition. And so she just said, I've been meeting with him, but he hasn't actually talked to other physicians in the that's probably whatever. Will you meet him? Sure, we'll meet him. And he had been meeting these community members in the park across the street from his office. He said, the man is a public servant. Kirk and I have great reverence for this man. So we just meet him in the street across from his office, and it's kind of like what we're doing now. We learn each other's background, what we've been doing with our career. He has experience in malaria prophylaxis and vaccine development. So we just talk through all of that. Interestingly, he had met Rabbi Merlin, who is who had had the idea of the Pono Coalition for Informed Consent, because same thing, he had met frustrated community members who didn't have access to finding out information. So he had met Dr. Pang, and they had, so when we met Dr. Pang, he had actually seen a podcast that had gotten censored. And so he was really mad about it. His two hot button issues are censorship and informed consent. So he rolled out the vaccine program in Maui, inoculated probably thousands personally, is a pro-vaccine person. And what he says is, I gave the vaccine to everyone who wants it. And now enticement and coercion is inappropriate and I won't be a part of it. So he asked Kirk and I to then meet. So that's how we met Bruce and Sacha and Rabbi Merlin. And so that's how the Pono Coalition for Informed Consent came to be. And ironically, what we talk about is actually a lot of us, we don't agree on everything. Probably the lay members of the coalition would say that they're anti-vax. Dr. Pang is one of the most pro-vax people you can talk to, including this vaccine, but he's willing to talk about it. So, but then what happened is the Delta variant happened, right? So Kirk and I have kept very close tabs on a community of people for a year and a half. We knew who was getting sick, who wasn't getting sick. And then literally out of nowhere, we went from knowing of no one that was ill to knowing quite a few people that were ill. And we are in the orbit of hundreds of people. So all of a sudden our antenna went up and we said, this is different. This is a problem. We actually shut down our church and our food pantry for a week because we're like, this, it was like it exploded. And Kirk called Dr. Pang and said, this is what I'm seeing. This is really concerning. And he said, yeah, I'm hearing it too. And we talked about everyone needs to know that there's early treatment available. This is urgent. This is life and death. So I actually was on the mainland and Kirk and Dr. Pang, Dr. Milhoan and Dr. Pang filmed a webinar. How long were you there, Kirk? 5-6 hours. People from the public were there. There was a Q&A that went on. And they filmed this just talking about the fact that early treatment is available and talking through some of these, talking through your rationale for outpatient treatment. That is what has exploded in the press because Dr. Pang and Dr. Milhoan would dare talk about ivermectin and hydroxychloroquine, and we would dare talk about risk benefits and alternatives to consent, to the vaccine. So we have been labeled anti-vaccine, which we are not. And then, right, we're in trouble for talking about ivermectin and hydroxychloroquine. And I had a colleague call me, and that's exactly what he asked me. Is this just about ivermectin and hydroxychloroquine? And I said, no, it's about treating people. And there are lots of physicians that you know, because you've been working with the hundreds of them that are treating people, that if they can't get access to either of those drugs, or they have just decided I'm not fighting the political battle, they will use a regimen, a multi-drug regimen, sequential regimen, and actually exclude those drugs, but they are having effect in decreasing hospitalizations and death. So
that's the third paper, the paper by Paul Alexander that I was on as well, the nursing home paper that basically looked at all the protocols. And the answer is do something. Yes. You just do something. You can reduce mortality in seniors by 60%, and it can be any little combination of things. And so Dr. Brentios in South America and Dr. Chetty, who I did a seminar with, I was in with him on the other night. They don't even use hydroxychloroquine or ivermectin. They say,
I've
listen,
seen his protocol. Yeah.
yeah, it's so controversial. We just kind of time it, and they use a little. They use Singulair. They use cyproheptadine. They use prednisone, aspirin, and then Lovenox. I mean, the anticoagulants are probably most important, but there are many ways to treat it. And when I presented this on the Senate floor on November 19th, I held up my protocol. I said, listen, I use prednisone to treat asthma every day. I'm not afraid of it. I use aspirin. I'm a cardiologist. I use Lovenox. We have blood clotting, Eliquis. We use these drugs every day. This should not be and is not controversial. Oh, Dr. McCullough, you're being controversial. What do you think about? I said, really? I mean, all we have to do is change the label from COVID to asthma, and it wouldn't be controversial, right?
So, and a thing that we understand is we understand therapeutic index, right? We understand there's a ratio in dosage between what's appropriate and safe and then what is toxic. And so every drug has either a wide or narrow or therapeutic index. Ivermectin has a hugely wide therapeutic index.
And we're using drugs well within their therapeutic ranges. Yes. So ivermectin, we got PK data up to 36 milligrams a day. With hydroxychloroquine, we've never changed the dose. It's 200 BID. It's actually been studies in pregnancy. It's perfectly fine to use it in pregnancy. Prednisone, we initially we were going hard, going soft. Dexamethasone, we've never used, honestly. And in the RECOVER trial, they picked 6 milligrams. In the RECOVER trial, the mortality in those who got 6 milligrams was 22%. It was unacceptably high. 6 milligrams of dexamethasone is not clinically appropriate, And Fonseca and others in Brazil showed, listen, go with prednisone. It's a much more balanced steroid. We use it all the time in asthma. This dexamethasone thing was just a joke. When you actually want to use it for inflammation, you actually use 10q6 hours for ENT and cerebral inflammation. So this homeopathic steroid dose never flew with me. I never even prescribed it. We used prednisone, and then inhaled budesonide. That was actually really nice. Richard Bartlett was the one who innovated in Texas. He was on national news saying, "Listen, I think this works." And give Richard a lot of credit. There's principal and stoic trials, no randomized trials showing large reductions in hospitalizations with inhaled budesonide. You got to use a lot of it, but it works. So
you know what's really hard for me right now is I'm finding people right at the edge. I'm finding them like they're at 5 days in, 6 days in. I've been watching to see which way they would turn. I'm thinking about, okay, how's not a lot of respiratory symptoms. And then all of a sudden I see it. The respiratory symptoms start popping up. I'm trying to get them basic. I'm just doing like whatever I can. Pulmicort, something like this.
Yeah, basic.
The wait time right now might be 2 or 3 days for us to get them even that prescribed.
Right. So that's the reason why it's called SARS, sudden acute respiratory stress syndrome. They can suddenly go down. And uniquely with this virus is the microthrombosis. And every time it's been looked at. So what I do is actually when people are very mild, we use risk stratification. I can bring up the protocol if you want.
Yeah, go right ahead.
Please do. You can take us through your procedure, your protocols.
So what we had originally had done is, and this is all what's in the home treatment guide. The home treatment guide came out in October from the Association of American Physicians and Surgeons, and now it's been transitioned over to the Truth for Health Foundation, been updated, and Jane Orient and Lee Vliet did it. But the protocol is this, and what I did is I published it in multiple places to absolutely nail it down, and now it's been copyrighted. U.S. Patent Office is copyrighted. So this is because I had to. It was just too darn important to do this. So COVID-19 like or confirmed illness, self-quarantine at home, contact tracing, contagion control, ventilate the house. And I can tell you one of the things we've done now in the top box is we've added betadine, dilute betadine, oral rinse and gargle, spit out, and then betadine nasal spray or Q-tips up the nose. And that works prophylactically, and it works in acute treatment to cut down the viral load. And one of the problems with Delta is the viral load is massive. And so
we can go on tangents all day long, but that is actually something that we noticed is how, right, that with the Alpha variant, it didn't go through households. This, if we hear of it in one member of the household, we just wait because it's going to go through.
Agree. I completely agree. I talked with John Littell today, who's seen a lot. And when I got on national news a few months ago, I said, listen, Delta, the British are telling us Delta is easier. We are communicating with India. They crushed the curve relatively readily with drugs. You know, India got out of control and immediately got under control. And then when I started seeing Delta firsthand, I said, oh, this is different. This is is harder to treat. It's affecting younger people. It appears, and it's landing younger people in the hospital. And I've lost some young patients. So, you know, I think Delta is a whole new game. And so let's just go through it. So the first thing was risk stratification. So we learned from the Oxford group and others, if you're under age 50, and we used hospitalization and death as a primary outcome, under age 50 and healthy, there's less than a 1% chance of hospitalization and death. And if you go down the left-hand side, nutraceutical bundle, standard nutraceutical bundle, and people can add things to it. They liked N-acetylcysteine. I said, add it. They add lysine, add it. You know, nutraceutical bundle, not because it's curative, but because when patients have deficiencies, every study looks at it, they're at higher risk for bad outcomes. So it's one of these things, can't hurt, maybe can help. Naturopathic doctors have come on very strong in the COVID-19 response when a lot of allopathic doctors didn't. I said, bring it on. I work with these guys and I like them. Now, under age 50, watchful waiting. If severe symptoms develop, then they move over to the treatment category. Otherwise, they complete self-quarantine and go home. So at my employer, by the time I got COVID in October, I called employee health. I said, do I need to get tested to return to work? Whatever. They go, no, are you kidding? They go, we gave that up months ago because the nurses were testing positive for 3 to 6 months after COVID-19. They said, as long as you don't have a fever and your cough is under control, come back to work. So this business of 10 days, 14 days, that was all witchcraft and not supportable. And to this day at my job, I've never had a test. I've never had a test at my job. I had a test to make the diagnosis of COVID-19, but I've never had a test for employment reasons, what have you. And asymptomatic testing should not be done. Should not be done. It's not FDA approved for any product. And the World Health Organization says, don't do it. So all this getting a nasal test before you fly to Hawaii and all this stuff should not be done. People should just walk past the station.
Okay, I'm going to say something really dangerously controversial. And we've learned with Delta that here in Hawaii, our observation is there are vaccinated who have become ill. There are vaccinated who have transmitted it within their households. Currently, in this timing in Hawaii, they have had milder illness and less hospitalization and death. The other day, I looked at the hospital census. It was 80% unvaccinated, 20% vaccinated.
I mean,
but the testing to come to Hawaii, you've had to test until July. Then we stopped testing the vaccinated. So I don't know. But I have a suspicion because what we've seen of those who get sick, first, those who got sick initially, because we hadn't really had illness in such a long time. It was so mild at first, they were in complete denial that they could actually have COVID. No, I just have a cold. No, I just have a cold. No, I just have a cold. And then that's when no. But so I think because it's so mild, and I think I'm suspicious that we're missing some vaccinated who aren't getting tested.
Just a couple observations. So the CDC tells vaccinated not to get a test. Most hospital protocols are they're not testing vaccinated before heart cast and surgery, which they shouldn't have been doing anyway. By the way, asymptomatic.
So it's either test or don't test.
It should not be done. So there's differential testing encouraged by the CDC. But you're right. I mean, there is a massive number of vaccine failures. I mean, the current number that CDC just put out was 21% of hospitalizations are fully vaccinated. That's a lot. They went from 1% 4 weeks ago. How was it 1% 4 weeks ago? Now 21%. So are fully vaccinated. And the CDC doesn't have all the cases, but they have 21,000 full vaccine failure cases on their website. You know what the mortality is? 20%. So the vaccinated don't have any freedom from mortality. In Israel right now, it's 86% of COVID-19 patients are fully vaccinated. It's basically everybody in the hospital is fully vaccinated. So I think honestly, we're down to the fact that the vaccines probably don't work. And if they do something, it's pretty minimal. So,
and it may be, this is a personal theory I'm working out from observation, right? I know personally know bad stories, including death of people that got infected within the first 2 weeks post-vaccine. So we know the phase 2 trials showed immune suppression, right? In those first
right. So in Pfizer's briefing booklet, they showed that there was an explosion of cases after the first vaccine, and then reports from Israel and France and elsewhere showed that there's a susceptibility period. So as we push through mandates to vaccinate into the Delta outbreak, given the observation that the vaccines don't cover Delta, now we're just going to make people, we're going to actually even drive more disease with this vaccine push. But let's focus on the algorithm. So down the middle now, bamlanivimab is out because it didn't cover alpha. It's no longer commercially distributed. So we're left with the Regeneron, which is casirivimab and indimavab. And that's a 1 hour infusion. Don't rush it. If you rush it, you can end up with some problems. And I've had one patient where it was rushed and he got hospitalized with a severe reaction afterwards. Otherwise, it's pretty well tolerated. There's some GI hypomotility and some general sickness after you get the antibody infusion, but in general, it works. Great paper by Verheuze in the Infectious Disease Journal, showing that every day that you wait on the monoclonals, people get worse. So you can give them up to 12 days, but give them on days 1, 2, and 3 on a senior. And even if they look good, don't wait for severe symptoms. If they look good, give them the monoclonal. But President Trump, they didn't wait for him to get severe symptoms. They gave it right away, and it works great.
And we do have that available locally. So that they're
underutilized.
Exactly.
80% of these sit on the shelf. We've got 500 million pre-purchased doses. Nobody's using them. It's so
unfortunately, right now, I had a 64-year-old status post-cancer and radiation therapy, and she and her husband fully vaccinated. She was becoming ill, and I said, "Oh, you've got to go in and get the antibodies." She called up and they said, "Oh, our cutoff is 70."
Yeah, so I've had that too. So you're not sick enough. These arbitrary cutoffs. How about this one? If you've been vaccinated, we're not going to give you the antibodies because the vaccine should give you antibodies. That's come up. All these arbitrary, this is the worst one. And this resulted in a death. I had a 38-year-old man who I was advising on. There was another doctor getting sicker, obese, go to the ER. I said, get a monoclonal antibody infusion. He was way behind on early treatment. He got 1 or 2 days of early treatment. He goes to the ER and they decide to admit him. Click, he's admitted. Oh, sorry, you're admitted. We can't give you the antibody infusion now. Mm-hmm. Yeah, it's just an arbitrary thing. It's completely arbitrary. So there's no age cutoff. My somebody in my circle, my church, we just sent him. It was a little bit late, but he got a monoclonal antibody infusion. It made a difference. He's 40. He's 40. You don't need to be 65 or 72. So what's happening is there is a distortion of treatment that's at all levels. We've been talking about suppression of early treatment. Listen, we got EUA monoclonal antibodies. There's not a straight story on where these antibodies are, where are the rules to use them. I've had conference calls with DeSantis' group in Florida, who's trying to take a lead on this, saying, listen, this is crazy that again, we are punishing people with COVID-19 because we're not treating them properly. So let's just kind of go through this. Down the middle, 2 or more anti-infectives. Hydroxychloroquine's got 250 supportive studies, a 30,000 patient study from Iran, all the small randomized trials and meta-analysis by Ladapo, outpatient trials, positive. The only early inpatient study, Henry Ford, 3,000 patients, positive. The only thing we have neutral on hydroxychloroquine are 5 small, very late randomized trials, and only 2 of them are placebo-controlled, and none of them have legit endpoints. The endpoints are doctors determining how much oxygen people get. So the neutral hydroxy trials are not valid, and that's what people are holding up as the reason not to use hydroxy. So you have hydroxy, 200 BID. We combine with the Zithro and Doxy largely because they have some intracellular anti-infective impact, and the Zithro, maybe some antiviral activity, but more importantly, there's about a 2 to 3% overlap with chlamydia, pneumonia, and mycoplasma. And I think in Taiwan, there's a paper out of Asia that showed that. I've had that in my practice, and believe me, when you get the combo, it's really severe, and it can happen in young people. So you always want to use one of those antibiotics. If we're in Russia or India, Pakistan, we can use favipiravir. Japan, they use it. It's an oral form of remdesivir. I can tell you, I'm not too impressed by it. It works pretty slowly. I've been communicating with the Japanese. They only use it in the hospital, maybe after they get toxicity for remdesivir. So FAVI is, the fact that we never commercialized FAVI in the United States is not a loss. Respiratory symptoms are developed by day 5. Inhaled budesonide, we're now using inhaled budesonide much earlier based on STOIC and the principal trial. We use a prednisone, 1 milligram per kilogram for 5 days. That's a little bit high. I got to tell you right now, I think my common dose is I do 20 BID for 5 days, then 10 BID, and then 10 QD, something like that. Colchicine from the Col Corona trial, 0.6 milligrams BID for 3 days, then 0.6 QD there for 30 days. Underlying medical conditions, microthrombosis risk. We're now putting everybody on aspirin 325 a day for 30 days. Patients with atherosclerosis like me, I took it for 90 days because the Japanese were reporting these late strokes and infarcts. There was no way I wanted to get burned with a late stroke. Aspirin 325. There was a paper from UCLA, by the way, that shows massive upregulation of thromboxane, production of thromboxane A2 and B2 with this. I mean, it is a massive outbreak, upregulation. And then full dose low molecular weight heparin, that would be enoxaparin 80 to 120 sub-Q BID, or the standard doses of apixaban, rivaroxaban, dabigatran, et cetera. So this is what's called sequence multi-drug approach. We use oxygen concentrators at home. People buy them on Amazon, or they can get them from a medical supply house, and we crank the drugs. Now people say, well, can you add fluvoxamine? I said, go for it. The FLCC group, which is another group that sprung up here, Corey's, Merrick's leadership, they want to use an anti-androgen, a common anti-androgen that's like Proscar. That's fine. I honestly, I think it has a pretty minimal effect. To me, the biggest things that make a difference are the steroids and the full dose anticoagulation for sick patients, honestly.
That's what you're finding, Kirk, right?
Now, what's the short course? We used to with alpha and beta. We never really had gamma here, but alpha and beta variants, we used to go 5 days. Like Sebastian Gorka, I've done a lot of TV shows with him. He took 5 days, sequence multi-drug 5 days. Dan Ball on real 5 days. I got to tell you what, for me, it was 10 days and I had pulmonary involvement. I was on steroids day 17. It's a long illness. Now with Delta, oh my gosh, it is the longest. It's going on forever. I don't think anybody can give about 5 days of treatment. Nobody. We're going 10 to 30 days of treatment. My dad got it in a nursing home, pretty sick. 60 days of treatment. He got 60 days of hydroxy, 60 days of Lovenox, 60 days, and he made it through. But anything less intense than that, I'm telling you, the seniors go down like a rock and they die. So they need intensive treatment. The point is, what we're seeing everywhere is a massive undertreatment, massive. People get hospitalized. You know what they get? They get 5 doses of remdesivir. They never get to the 5th dose because there's so much liver toxicity, and they get 6 milligrams of dexamethasone a day. That's all they get in the hospital. And families beg for aspirin. They beg for Lovenox. They beg for ivermectin hydroxy. No. And the families go to court. They actually go to court and they try to get a court order. Sometimes the judge grants it, sometimes not, but they're begging for standard treatment. And in the hospital, they won't do it. They will not administer a monoclonal antibody infusion in the hospital. They will not. So there is something going on. Just like doctors are not treating outpatient, the inpatient standard of care is horrific. That, and it's basically the inpatient care. They probably could have saved half the lives that were lost just by high quality inpatient care. This is higher quality and more intensity than what patients get on the inpatient side for a fatal illness. And it's shameful. And in our hospital, you know what the standard orders were? Cefepime and vancomycin. Like what? Cefepime and vancomycin. I just got a text right now. My loved one is in the hospital and their featured drug is levofloxacin. It's like, what? I mean, doctors in the hospital are lost. They're in a trance. Doctors' minds are in a trance. They couldn't make a right decision on COVID if you paid them. They cannot make a right decision.
Let's go back to hydroxychloroquine controversy, because this is one that Kirk can speak to as a pediatric cardiologist and as a with a PhD in cardiac physiology and pharmacology. A lot of people. So hydroxychloroquine has a narrower therapeutic index And so the controversial trial that's out there, people point to arrhythmias. So can you both speak to
did it suddenly get dangerous? That's the question, right? So hydroxy's around for 65 years. It wasn't dangerous in 2018. We treated patients with rheumatoid arthritis. We treated really sick mothers with lupus, pregnant women with lupus, in the hospital, lupus, all the lupus, pericarditis, all the stuff we saw with lupus, hydroxy 200 BID. It was not dangerous in 2018. It was not. It was not. Actually, the biggest danger in hydroxy is G6PD deficiency. That's the biggest danger, is an acute hemolytic anemia in an African American or an Asian Indian who's got G6PD. That's the biggest risk. So when you're prescribing hydroxy, you have to ask them, have you ever taken Bactrim and had blood in your urine? And they start asking questions like that to try to figure out if they have G6PD. But nobody even talks about that. So what they did is there was a fabricated case that there was some type of cardiotoxicity with hydroxy. That, hydroxy's got about the QT prolongation of any standard antihistamine. And it's just the QT goes out a little bit and it's steady. It doesn't promote torsade de pointe. It doesn't do any of these other things. And to make the point, we had a 56-year-old woman really sick in our hospital with COVID. And in the unit, she developed torsade de pointe. And she had it and she got CPR and she died of torsade de pointe. She's 56 years old in our ICU at Baylor. Guess what? Not a milligram of hydroxy. None. The point is, sick people can get arrhythmias and they can get QT prolongation in the ICU, in the milieu. And actually, we have a figure showing the lead cytokine that prolongs the QT interval is interleukin 6, which is the big cytokine elevation in COVID-19. So hydroxy has basically been exonerated from any worry in COVID-19. And even the NIH trial of hydroxy, the trial, placebo-controlled randomized trial that everybody wants to point to for neutrality, was completely neutral on safety, completely. So hydroxy, for just like everything in COVID-19, again, was to promote fear, suffering, hospitalization, and death. And hydroxy is right in line. We could go on to ivermectin. So ivermectin has now been.
Do you have slides on these? Do you have slides on these that you want to put up?
Yeah, I mean, I have slides on all the drugs, but that's like a different presentation. We can go through. But the level of evidence.
So Bruce, you can put the docs back up on the screen if you want.
Yeah, but what I'm saying is the level of evidence is really substantial for all these. It's really good. Actually,
go ahead.
Let me just share the screen just one more time.
Okay.
Because give me back the screen for a second. Because what I want to say is the biggest thing that I would say is that, listen, does this reduce to practice? Does this make a difference? And what we have is this became a standard. So in Italy, all these treatment groups arose. So in the United States, we have AAPS, we have Frontline Critical Care Consortium, we have AFLDS. In Italy, we have Terapia Domiciliary COVID-19. They got to the point using this protocol, they got to 0 hospitalizations in major cities in Italy because they just treat people, or they got it together. It's led by a bunch of hero doctors. They've got Heart and Bird in the UK. They've got COVID Medical Network in Australia. They got PANDA in South Africa. So these concepts were reduced to practice. The best, we could never get any randomized trial funding, but what we could do is high quality observational data and looking at what people were doing. This was in Dallas, and compared to the Tri-County area, age adjusted for death, we had a 74.9% reduction, and deaths are really low when you're treating adults in primary care. Only treat 25% of a primary care. It's people over age 50 with medical problems. And then hospitalizations, even a larger reduction versus the Cleveland Clinic predicted. And so we published that. Vladimir Zelenko published the exact same findings in Monroe, New York. And this is the best we have. There are no randomized trials of 4 to 6 drugs in a sequence multi-drug approach. None. And there's none planned. There's none planned. People say, well, Dr. McCullough, this isn't good enough. I said, listen, sorry, this is all we're going to have. There's nothing planned. Here's the Paul Alexander nursing home study. They did different things. Hydroxysteroid anticoagulants. How about azithro and hydroxy? Hydroxy and doxy. Hydroxy and azithro. Doxy alone. Hydroxy and anticoagulants. It kind of doesn't matter. As long as you do something, you reduce hospitalization. I'll be happy to send these to you guys. You don't have to struggle with these. Also,
it comes to a point now is the ones who are coming up with all these data are the people who are treating. And now we've run into a situation of equipoise that I am not going to put someone into a randomized controlled study where it would be unethical for me to put someone in a placebo versus a treatment group when I know these data are out here.
Right. The only thing I would do, Kirk, is test different combinations. Just like in HIV. Once we got to combinations, it was just like in cancer, we just test different conversations.
Well, we would do that in Marfans, right? We were looking at ARBs versus beta blockers and stuff, but you weren't going to take away and give them nothing. That would have been inappropriate.
Agreed. And we're at that point, and the innovation in 18 months. And what I tell people is, listen, I'm an internist. I maintain my boards in internal medicine. I'm a cardiologist. I maintain my boards. I've done a 1.5 year COVID fellowship. I have reviewed thousands of reports. I got 45 papers on this. I have a lot of people asking my opinions, including the US Senate. In the last week, I've been called by the most powerful person at the Federal Reserve, by very powerful people in the Vatican, by multiple state senators. And what I tell my detractors is, listen, I'm sorry, but my opinion matters and I have authority. And it's very important. I think we have to step out and tell people we have authority, and others are not presenting this. Others are not even discussing this. Others are actually completely oblivious to this. I honestly think many media doctors and public health officials are completely oblivious to the body of information supporting early treatment that we rely on. I think the work, this is the most gratifying work I've ever done in my life. The fact that we've disseminated information through treatment protocols and organized groups, we've probably spared millions of hospitalizations. And in the United States, our CDC had estimates based on everything they knew. They had us between 1.7 and 2.1 million deaths. We basically shut it off at about 600K. We crushed the curves at the end of January before any vaccination effect was there. And now we're just battling through Delta. We're having a lot of cases, but thankfully we're keeping the mortality down.
Peter, a lot of people ask us, and I'm sure you've been asked this a lot, but what about, why am I not hearing this? Why are all the rest of the doctors saying this? What I describe it as is what we're used to when we're teaching medical students and residents, is people are just parroting what they've heard. They're not actually looking into the data. So they say, oh, we know hydroxychloroquine doesn't work. We know ivermectin doesn't work. We know steroids don't help. No, they're just saying what they've heard. They haven't actually done the due diligence to actually look at the data. I was in a meeting with people and I gave them all the papers. They didn't even look at them. They were like, oh, I don't need to look at this. Right?
Yeah. Well, listen, 2 years ago, I was the endowed lecturer at Harvard. I was all over Harvard. I was giving lectures and all this fanfare and all this wonderful stuff. Now this year, I was an endowed lecturer at another Ivy League school. And they said, what's going to be your topic? I said, early treatment of COVID-19. He goes, oh, we've had lots of grand rounds on COVID-19. I said, have you ever had one on how to treat it? He goes, no. I said, well, wouldn't you want to know how to treat it? And he goes, okay. So I filled out the forms, I did contracts and CME, and I go slides and vetting and conflict. I did all this stuff. The night before, panic call. The guy, my contact there said, listen, we can't have you give the lecture. You cannot give the lecture. I said, what happened? They said, our entire infectious disease department went to the chairman of medicine and they said, you cannot have Peter McCullough deliver this message. You cannot deliver the message. I'm telling you, it is actively suppressed. There has never been a grand rounds anywhere in the country to present on early treatment. There's no Harvard protocol. There's no Mayo Clinic protocol. There's no Baylor or Emory. The major academic medical centers have not lifted a finger to spare a single hospitalization. They have been complicit in promoting as much suffering and hospitalization as they can promote. It is shameful what they've done. It is shameful. And this is a walk of shame that's going to go down the rest of history. These people actually cannot even exchange an email. They can't even look me in the eyes. They can't look me in the eyes. That's how ashamed they are of themselves.
But so we're living through the chilling effect that doctors are living through, right? I mean, we came together as a group of individuals that don't even completely agree. We just agree that we should share information.
Yeah. And
now 2 of the 3 physicians involved are having their medical licenses investigated. They're getting articles written about them in the press that are not favorable and actually not representative of their words. We actually have learned the hard way that we trusted that they would, if you give an interview, they'd actually represent you fairly, which they don't. And so they've distorted what was said.
I treated my patients all year long. It became obvious. I testified in the US Senate. I became basically a media personality. End of January, 2 people show up in suits. I have the busiest clinic at Baylor. I got a stellar record. I've got great grant funding, leading publishing doctor. All the doctors see me. All the people in the C-suite see me, right? I get walked into a room by 2 administrators saying, turn in your badge. We're shutting down your computer access. You're done. You're done. I said, no due diligence. There's supposed to be 2/3 board vote. There's supposed to be all these, you give you time to transition your practice, whatever. I think if they could, they would have just shot me dead right there in the room. I said, any reason? They said, no. I said, well, I think this is retaliation for me treating COVID patients and what have you. And I make sure I got that documented. And then I went on a mad scramble. Fortunately, the doctors are like pro football players were like, I got cut. I got picked up by a new team. I went into a private practice, same building, same complex. It took me 60 days to transfer all my patients, but they had hired people that night to call my patients and tell them I left Baylor. And so, so I ended up having to negotiate a separation agreement, which I did, what have you. And then the day they announced their vaccine mandate, they actually go to the press. They go to the press, the hospital does, and says, we're suing Dr. McCullough. We're suing Dr. McCullough for $1 million in damages for his public views on this. And he violated a separation agreement, what have you. And it's a frivolous lawsuit, but they did it to basically show the other doctors that they're going to make an example out of me. And so now I'm lawyered up and I'm just paying massive amounts of money, just fighting this, this lawsuit, and which is a frivolous lawsuit. I can't get any justice in the courts because just like all the minds are perverted right now in medicine, they're perverted in law. We can't get any justice anywhere. And then next they're going to be hunting the medical license. And they said they're hunting the medical license for people who give misinformation. Well, who decides misinformation versus information? So when I go in the media, I am pinpoint in citing the data. I know the trials, I cite the data, and somebody made a fake Wikipedia page on me. And the Wikipedia page has a whole section on COVID misinformation and says that I am giving COVID misinformation. And I can't get rid of this Wikipedia page.
Well, we are now the #1 disinformation site in the state of Hawaii. So
yeah, so they're going to hunt our medical license. Listen, this is going all the way, you guys. Yeah. There's not going to be any justice. There's not going to be, it's in the minds of people now to promote fear, suffering, hospitalization, and death in order to get a needle in every arm. And it doesn't even matter if the vaccine works or not. It doesn't matter. It doesn't matter. It doesn't matter.
Let's back up there, because as I've listened to you, as I discovered you, originally, people believe that this vaccine is like any other and that the system works. So in principle, we agree with vaccines. I've had every vaccine I qualify for.
Me too.
I have defended the medical system against skeptics and say the system works. The FDA works, the NIH works, the CDC works. It works, it's trustworthy. Everybody believes the system, everything's working the same and it's trustworthy. People have said that. The system works. Why are you not trusting these agencies? So talk through your evolution of feeling about this vaccine.
Okay, so vaccines.
The vaccines.
So I published, what I needed is, I somehow I got a sense really early on last year as it started that I needed a window to America. I needed a window. And the typical publication stuff that we could do wasn't enough. So I became a regular contributor to The Hill, which is a political journal that's published once a week. And I started publishing a series of op-eds in The Hill so I could actually start to speak to America, because I had a sense that nobody was talking to Americans. No one was actually giving Americans a straight story. So I published a whole series of op-eds. I completely predicted every twist and turn of this pandemic. I nailed every one. While these other people were doom and gloom in that session, I published one in the summer that said the great gamble of the COVID-19 vaccine program. This is before the vaccines came out. I just said it's a gamble. We're putting all our eggs in one basket. We're not doing any early treatment trials, no therapeutics. nothing. We're just putting all our eggs in one basket, and this basket looks pretty scary. There's no live attenuated, there's no inactivated, there's no protein-based, they're going to be gene transfer technology platforms. There's gene therapy. These are 24 gene therapy platforms designed to treat Fabry's disease or Pompe's disease or Gaucher's. They're actually designed to be long-lasting and to produce a protein product or reverse transcribe and actually put genetic material into the HERV region of the chromosomes. And so there was nothing about these vaccines that was conventional at all. They didn't even try. In fact, there is a conventional vaccine, Novavax, the protein vaccine, and they're slow walking over, and it's every bit as good as. So believe me, the gene transfer part of this is really important. And so as these race forward, we saw 90% efficacy, but wait a minute, the rates of COVID were less than 1% in both groups. How can that be? So they recruited a bunch of people who never got challenged with COVID. So we knew from the beginning the vaccines were probably going to fail because they were not sufficiently challenged. You got to go out and get some red hot COVID patients in your face to get challenged. They didn't have these people. These people were doctors and other people who were double masking and in WebEx all day long. They weren't coming in contact with COVID. So they had absolute risk reductions less than 1%. We knew that from that. There was a publication by Brown et al. From Canada. So listen, the vaccines are not going to influence the pandemic. They can't. The absolute risk reductions are too low. They're too low. And so, this 90% vaccine efficacy was the most favorable way you could present the data, but in no way was it going to have a population impact. But when they came out, people volunteered for the program. I didn't encourage, I didn't discourage. Oh my gosh, all the doctors, everyone just poured in. They got their vaccines. People were waiting in line for hours, getting dehydrated, waiting for the vaccine. So about 70% of my practice took the vaccine, but my practice is internal medicine, cardiology. That's fine. But what happened was these really disturbing things. So this idea of having pregnant women take the vaccine, they're strictly excluded from the clinical trials. Everything new is pregnancy category X for sure, because it could be dangerous. New seizure drug, pregnancy category X. New diabetes drug, X. So and excluded from clinical trials. And next thing you know, women go in the center and they actually take the vaccine. And the consent form has a special check mark that says, I'm not pregnant. And I'm checking this box. And if I am, that our consent form says, there's not much known about pregnancy. Even the label that was given to Comirnaty for BioNTech says right on the label, not enough information to know about pregnancy. So the fact that pregnant women were kind of at first just volunteering for it, and then they were encouraged. And then before you know it, the American College of Obstetrics actually says to do it, which is really, really scary that a college, an academic college, would say to give a pregnancy category X product to pregnant women is unprecedented.
Hey, Peter, the New England Journal of Medicine article on it was June of this year.
I saw it.
On table 4, I was really concerned about table 4 because when I looked at the subnotes, if I read that correctly, there were 827 patients that completed the study, but 700 of those were in third trimester. And then when you looked further in the subnotes, for first trimester of spontaneous abortions, there were 96. So it's not a 12.6, it's actually a much higher. If you look at if you get the vaccine within the first trimester, you're up in the 80% of having a spontaneous abortion. Did I read that correctly?
Right. So there was a ton of letters that went to New England Journal of Medicine. I was with a group from Canada who looked at this really carefully. We work with Ray Stricker, who's at UCSF, and he runs a fetal loss clinic. Ray's one of the smartest guys there. And we said, listen, this doesn't look right because they divided by everybody who took the vaccine later. You can't do that. I mean, there's been fraudulent stuff done in the New England Journal of Medicine. So it's somewhere between 12 and 83%. It's just that all these different windows of time, nobody's been followed for 9 months, so we can't really know. So what we did, because we didn't get a letter to New England Journal of Medicine, we published something in an internet journal, Trial Site News, where we just said, listen, it's inadequate. It's pregnancy category X. The vaccines clearly have a dangerous mechanism of action, and we shouldn't be injecting pregnant women. And we shouldn't be injecting women at childbearing potential because we don't know if it can cause birth defects or fetal malformations and other things. We just don't know. Just don't do it. You just don't do it. There's a wonderful paper in Annals of Internal Medicine recently showing pregnant women who get COVID have better outcomes than non-pregnant women the same age. So pregnancy is actually a low risk state for COVID-19, not a high risk.
However,
low risk.
so when we talk risk, benefits, alternatives, right? We've seen them in the hospitals that we work in. We've seen bad outcomes in pregnant patients.
We have too. Believe me, anybody can have a bad outcome if they don't get any early treatment.
Yeah.
Okay. So we've had fatality in our extended family. Listen, I'm not saying it's not a mild thing, but in general, it's milder than being non-pregnant. And anybody with severe symptoms that languishes for 3 weeks can do badly.
Yeah.
Now, a pregnant woman gets started with hydroxy right away. Just like if a lupus patient had a fever, we would treat with hydroxy and prednisone. Why are we not? Fever itself can precipitate a fetal loss. So this idea of not treating pregnant women is awful, but the bottom line is they are at lower risk statistically. Okay, so pregnant women with childbearing potential, and the big one was COVID recovered. COVID recovered, FDA, Pfizer, Moderna, everybody knew you can't get COVID twice. So of course you're excluded from clinical trials. So now the vaccine just creeps along and says, yeah, COVID recovered, why don't you take it? Or you could get it twice, or maybe you could take, and then the mandates. Now the mandates have made people really uncomfortable. So wait a minute, I can't get it twice. Now there's 3 papers that show it's actually excess harm. If you go ahead and juice yourself with the vaccine, you've already COVID recovered. And so now we're in trouble. We got 15 studies showing COVID recovered. Basically, you can't get it twice. There's a claim that there's been a recurrent case. And every time I've looked at it, I've looked at every one of them, it's a false positive PCR somewhere. It's not 2 episodes of severe disease. And to make things worse, the CDC methods for the PCR, which was used by all the original labs, can't distinguish between the flu and COVID-19. So invariably, some people had flu one season and COVID-19 the next season, but it's not double COVID-19. Impossible.
Yeah, it's really encouraging, the data out of Israel. I know it still has to go through quite a bit of, evaluations, but in terms of the protection of the natural immunity versus the vaccine protection is pretty impressive.
But though they say, 13 times better. It's like, no, it's a million times better because you can't get it twice. Yeah. So even this paper published in MMWR from Kentucky, they had 500,000 cases. They go, oh, we think we had 234 people had it twice. It was just people who had 2 positive PCRs at different time points. They didn't even know who was sick or not. The same thing in a study in Denmark. Oh, they had some antibodies here, but they had COVID. There's been 100 cases where the one that best is one from France, where they said, oh, this guy in France, he's 56, he's got asthma. He was positive on his, can you turn off that light thing? He was positive on the PCR over here, but he didn't really have any symptoms. And now he's sick with the South African variant in January. It's like, no, that's not 2 cases. That's a false positive PCR in COVID. So in order to do this, we just made a movie recently. And as part of the movie, I made, like you, Kirk, I made some house calls. And I made a house call and I literally got in the face of 2 people with red hot COVID, no mask, talked to them, this and that, came back and visited them 2 weeks later. And I wanted to show America, you can't get it twice. And I'm telling you can't get it twice.
You're opening this to my experience, which I had it early. I only knew, we antibody tested 100 people in our church that had either worked in the food pantry or were family members of the food pantry. So we tested these 100 people. In my household of 4, I was the one antibody positive. And I can point to a week when I was traveling that maybe I didn't feel exactly right. That's the best I can do. So it was incredibly mild. I didn't lose my sense of taste. I didn't lose my sense of smell. But I have believed in natural immunity like other diseases. So every time I apply for hospital privileges, it's either have you had this disease or have you had the vaccine? It's an either or. So in this disease, I have had it. And I have actually tested it because I do locums on the mainland. I'm on an airplane once a month. And then Kirk and I have persisted in doing international medical missions. So we've been in Tanzania 3 times since November. We've been in Iraq twice since January. And then in addition, on purpose, I have volunteered to take care of COVID patients as an anesthesiologist, which is supposedly high risk because of aerosol generation. I take care of them to save my colleagues who haven't had COVID yet. I'll take care of them. So I feel like I've truly tested this immunity.
Sure. I mean, Cleveland Clinic, the paper by Shrestha et al., they had 2,500 people, didn't take the vaccine, COVID recovered. They had about a 5% background rate, went back into the workforce. Nobody got COVID, just like me, just like you. You don't get it twice. And this is one of the fear promoting aspects of the pandemic is they will never grant natural immunity any credit. Despite that, city-state of Monaco is granted natural immunity, you're good. I think even the Israeli passport system recognizes it because the vaccine obviously doesn't work. So if the naturally immune who took the vaccine, they're the only ones who actually are okay. And now to say in Texas, we have an executive order in April to recognize natural immunity in the state institutions, not the private institutions. But I tell you, we have to recognize natural immunity. There's demand letters in the CDC saying, listen, recognize it. We got to get past it. I work in a big practice now, and we got a bunch of office locations. One of the first things we fill out in the application is, what's your status? COVID recovered. We want to know, because COVID recovered, we can staff these offices, and we're not going to have everybody out with COVID-19. But no one is keeping track of that. The CDC doesn't keep track of that. That no one in the hospital, no one's keeping track of that.
At our church, I did, because I tested all these people and I knew who was positive. And then as Delta came through, you knew who was safe.
Yeah.
For all the people from a year and a half ago who had it. A year and a half ago.
Okay. The reason why we're talking is these are the type of points we have to talk up.
Yes.
The points are, there's no asymptomatic spread. It basically doesn't happen. People have incipient symptoms. That's how they spread it. COVID immunity, you can't get it twice. Third point is, it's treatable early. We got to treat it early. Okay. Fourth point would be that, the vaccines, despite their best attempts, the vaccines aren't effective. If they are effective, they're differentially effective. And I give a presentation for the Heritage Foundation in Washington, a bunch of really big leaders, and you could hear a pin drop at the end. And I told them, listen, the safety signal on the vaccines emerged January 22nd. The limit on mortality per year, all the vaccines combined, 278 million shots, 70 vaccines, the limit on mortality per year is 150. 150. We are at 186 January 22nd with only 27 million Americans vaccinated. We were already over the line. If we would have had a proper data safety monitoring board, and I do that stuff, I'm chairman of a lot of DSMBs, I would have shut it down. Would have been shut down in February. Vaccine program should have been shut down in February as being unsafe. Period. No discussion. Nothing. It was over the line in January. Instead, it's going full steam today, forced on Americans who don't want it. Everyone now knows somebody who died of the vaccine. People are the rates of vaccination started plummeting like a rock April 8th. Nobody's taken the vaccine for months. These vaccine centers are empty, and nobody wants to take it because everybody knows somebody who's died of the vaccine. They don't want to die.
So back to my theory of time course, 2 weeks post-vaccine, very vulnerable. It does seem like there's a period at which if you're vaccinated, you seem somewhat vindicated. Currently in Hawaii, on Maui, you seem somewhat vindicated, right? Like, my disease is milder, I was less symptomatic, less hospitalization. It sounds like mortality is somewhat uncoupled. Delta is symptomatically bad, but mortality is less. But it appears,
the CDC data is confounded on that, meaning that, the vaccinated are doing worse in the hospital, but they're older. Yeah. They're older. So, younger people didn't take the vax, and so they ended up in the hospital. The older ones, I think 78% of the vaxxed hospitalizations, people are over age 65, and I want to say like 80% of the deaths are over age 65. So this idea of, well, if you take the vax, you get a consolation prize. I don't think so. It's a very unsafe product, and you wouldn't want to take it for a consolation prize. Even the FDA in the most recent deliberations says it doesn't protect against death or hospitalization. It's only just a binary: do you get COVID or do you not? That's all it is.
Peter, what do you make out about those high-profile resignations from FDA?
Well, it's interesting. The person who signed the approval letter for Comirnaty for BioNTech, she just resigned. That's so, and she signed that thing on Monday of last week, and now a week later she resigned.
So explain that to people, because people don't understand that very well.
Oh,
This
okay. So
FDA approval.
what happened was Pfizer, which is the weakest vaccine. So you have Moderna, which is 100 micrograms of messenger RNA. And then you have Pfizer, which is 30 micrograms of messenger. And they're very similar products. Moderna probably has a few more epitopes, and it probably has a little better coverage, and it's a much higher dose than Pfizer, which hits fewer epitopes and a lower dose. So it's interesting that Pfizer out of the gate should have been the loser, in fact, is a loser. But why would the FDA rush forward with an approval on Pfizer? I mean, it's just the most interesting. It's almost as if time was running out and everyone knew Pfizer was going off the cliff, and somehow they wanted to push it forward. And then you have J&J, which is interesting. J&J is given a certain number of adenoviral particles. It's still an untested gene transfer technology program, similar to AstraZeneca. But out of the gate, it was only 70% vaccine efficacy. Pfizer, Moderna, 90% vaccine efficacy. Pfizer now is estimated, Israeli health minister, it's hard from observational data, but pretty clearly they got Pfizer at 39% protection at fully immunized, and Mayo Clinic's got Pfizer at 42% in Rochester, Minnesota. So it's clearly Pfizer is below 50% efficacy, and it's pretty clear Pfizer doesn't last a year. So Pfizer actually does not meet standards for even an acceptable vaccine of any type. It has to be at least 50%. It's got to at least last a year. So Pfizer's not there. So what
protection does wane. Yeah. Okay.
Yeah. So there's a paper by Israel and colleagues from Israel showing the antibodies after Pfizer plummet 40% per month. So they just literally just fall off a cliff. So Pfizer, when it went for approval, gave no information on Delta. They just discussed the legacy data from the original trials from the Alpha variant, which is now long gone. And all they had is a little bit of extension data. They could have honestly had the approval meeting back in December if that's all they're going to do. They didn't consider any of the data in VAERS, none of the mortality data, nothing. And even then, the FDA told Pfizer, not approved. They got an extension of the emergency use authorization agreement. That's all Pfizer got. And what they did is they said, well, there's BioNTech and Pfizer, and they're legally distinct and maybe medicinally slightly different vaccines. The BioNTech vaccine has not been commercialized in the United States, but it's still kind of the same intellectual property. And so they said, BioNTech, you get conditional approval, but you're not on the market, and you have to do additional studies on myocarditis, a lot of them. So the FDA got out of that meeting. There was no briefing booklet. Normally there's a briefing booklet from the sponsor. The data is given to the FDA. The FDA does their own briefing booklet, and then they reconcile. None of that. Normally there's a panel of experts, there's presentations, a public citizen has a comment. None of that. It was a meeting with Pfizer and BioNTech. Pfizer gets not approved. BioNTech gets this conditional approval, but these additional regulatory milestones. And then the talking point comes out of the meeting, even goes to President Biden, that Pfizer's approved. And it's not. So what we saw there was probably, and it's probably the reason why the person stepped down a week later, we probably saw the greatest obvious step of regulatory malfeasance in US pharmaceutical history. And it just fits into what we're seeing. We've got very dangerous and completely ineffective vaccines. And now we've seen the greatest regulatory malfeasance of all time.
And what you just explained is so confusing that it's hard to explain. Do you see what I'm saying? And then
we had regulatory sharpshooters all over that, and we saw that, and it was almost as if there was the desire to create a false talking point that would fuel the hubris for even more vaccine mandates.
It's been approved.
For people who don't want
it's effective. It's effective.
It's not approved.
Why won't you do this to protect your community?
Yeah.
Right.
It's not approved. It's not safe. And it was just a false talking point. So we're actually in the wide open now. There is a definition for this. And the definition is propaganda. Propaganda is promotion of false information by people in those of position of authority. So it's in the wide open now. The censorship is in the wide open with the trusted news service. Now it's in the wide open when the Federation of State Medical Boards says they're going to hunt our licenses. It's in the wide open. You can't, you look at what's going around the world now, it's wide open. They rounded up children in Australia that brought them into an auditorium, kept their parents outside, and they started vaccinating the children without consent or anything else. 2 children died. It's in the wide open now. We should not be arguing data anymore. We are arguing something way bigger than data. We're arguing a program for mass injection of gene transfer technology platforms into human beings that's propagandized and socially weaponized, and it's fully operational. And it's coming. It's coming for everybody.
So one of the things in our Pono Coalition experience in the last week is that Kirk was in a meeting with Lieutenant Governor of the state of Hawaii, the Maui mayor, and some representatives from fire, police, EMT, Mothers Against Vaccine Mandates. And there's a Native Hawaiian culture here, obviously. We're in Hawaii. There were people in that room of Native Hawaiian descent who said, what you're doing is actually not in the spirit of aloha, because you're actually dividing us on whether we're vaccinated or not. And we don't want to be divided. And that in their culture, they're saying that's not what we do in our culture, but that's what this has done, is turned citizens, family members, friends against each other, because huge accusations of blame for if you dared to get an infectious virus and you must have done the wrong thing and it's your fault if you didn't get vaccinated, even if you're naturally immune, on and on.
Well, it's blame the victim. We're back to the same principles. This is from the very start. This whole thing from the very start was all about fear, suffering, hospitalization, and death in order to promote mass vaccination of a gene transfer program into human beings. And it's across the world. It's worldwide.
So I spoke with Dr. Bregan this morning. I spoke with him for his radio program, and I know you've spoken with him. And when I said to him, early on when I saw you interviewed, you would say, I'm not going to intent, I'm not going to why. That's for the journalists to figure out, which we've been waiting. There's some great journalists out there trying to dig into this, and we're thankful for them. But Dr. Bregan has written quite a book called Global Predator, We Are the Prey. And he was talking about some of that this morning. And I said, you know what, that's your level of expertise. And I'm glad.
Investigative, listen, some people have said, listen, it's because now it is genetic transfer of information to produce a spike protein. That's what it is on its surface. Okay. It wouldn't be too desirable for any of us to want spike production in our body, honestly. But that's overtly what it's doing, is producing spike protein in our body. Many have asked, what else is it doing? I don't know. We have other groups that are interfacing. People are looking at nanotechnology. They're looking at reverse transcription, what have you. But everything we learn about it is not good, right? Blood clots, persistent spike protein production, the neurologic injuries now. Senator Johnson's press briefing on neurologic injuries. It's all in the open. 545,000 Americans injured, the CDC is telling us, 13,000 dead, 200,000 hospitalized or urgent care visits, and it keeps going. And now, Americans know, Americans are afraid. They don't want the vaccine. I mean, if they stop the vaccine program tomorrow, there'd probably be a national armistice day. People would be so happy if the vaccine was stopped. There's not a single person who wants this vaccine. Even all these institutions that have the vaccine mandates, people dread it. Nobody wants the vaccine. Nobody wants this vaccine.
See, I'm meeting the people that want it, are excited about it.
Listen, I think the people who wanted it, they got it back in December, January, February. Listen, there's been so much vaccine around. It's everywhere. Anybody who wanted that vaccine could have gotten it 6 months ago.
And you get the free vaccine at Safeway.
Yeah, so no, it's over. Listen, everyone who wants the vaccine has taken it. It's now the fact that we've got slightly more than half the population doesn't want the vaccine. And I think we've got 40% of Americans scheduled to lose their job in the next 2 months. I mean, this is coming down to the biggest American showdown. When people say they don't want to take the vaccine, their stated reason is, I don't want to die. Yes. That's a pretty good reason. That's a pretty good reason.
So let's talk about the spike protein, because I told you I had mild COVID. It seems like younger mild COVID have some long COVID symptoms. I've had some long COVID symptoms with headaches and so forth. And just the sensation of, if you've experienced it, the people that have experienced it, something's not right, right? And I told you I was combing through all these papers, and I found this paper talking about increased pulmonary vascular resistance or generation of pulmonary hypertension because of the spike protein, the pathophysiology of that. So Kirk and I work in pediatric cardiac care. Pediatric cardiac specialists take care of a lot of pulmonary hypertension. It is an awful disease. So that was the first thing I saw that I thought, right? We all have our things that we don't want. Physicians have seen, oh, I don't want that. I don't want that, right? When I saw potential pulmonary hypertension, Kirk, I think probably that was Kirk in my first conversation where I said, you know, it's possible that the spike protein leads to pulmonary hypertension. So it seems like maybe not a good idea to have a vaccine that makes your body make that substance. So that was my first red flag where I thought, this doesn't seem right. So talk through a little bit of spike protein toxicity.
So let's take Pfizer and Moderna. So it's messenger RNA. The important thing are the caps, the nucleoside analog caps. And I've got a paper out with Tony Karagalkos from Athens, Greece, really, really brilliant guy. We have data and really conceptualization that this messenger RNA stays within cells for a long time. So a paper from Harvard by Ogata and colleagues showed that there is measurable circulating spike protein for 2 weeks after the first shot, for sure. Then after the second injection, presumably there's enough antibodies to kind of mop that up. But the cellular and cell surface expression of spike protein obviously is going to go on as long as the spike protein is there and it's used over and over again. Remember, a single piece of messenger RNA, natural messenger RNA, is used once and it's dissolved by the RNA aces. But this with the nucleoside caps must be, obviously you're only getting 30 micrograms or 100 micrograms. Not every cell gets it. So there must be a mosaic of cells that get it, but it must be producing spike protein enough to crank for a period of time before it's broken down. It's obviously not a 2-day vaccine. There's no way it's 2 days. And we know from the platforms that these were designed to treat people with monthly injections, once every 3-month injections, or once every 6-month injections. So before COVID, that's what Pfizer and Moderna and J&J and AstraZeneca had in mind. They had in mind treating chronic diseases with monthly or 3-monthly. They knew these platforms lasted a month, at least a month, maybe more. So here we just want to generate spike protein for a day or two, get some antibodies to it, and get out of it with immunity. That was the plan. The plan was just have it stay on the arm. Well, it looks like that's not the case. Our radiologists started telling us, wait a minute, the breast is getting changed on mammograms. Oh my gosh, this doesn't look good. Lymph nodes, the radiologists learn this immediately. Now every woman's asked, did you take the vaccine? Which arm? That didn't look good. And then the floor started to fall out of the vaccines in terms of safety. And then everything started happening in the last few months. So Ogata showed it circulates for 2 weeks. The cell surface expression of the spike protein looked like it was a disaster, and it was. So the myocarditis started being reported by the US military and in Israel and in France and in California and Kaiser. And before you know it, we had an explosion of myocarditis. I think we're now up to 5,000 cases of myocarditis. The FDA's got warnings on Pfizer and Moderna for this. Separately, the adenoviral vectors themselves are thrombogenic, and then the spike protein is super thrombogenic because it causes microthrombosis and endothelial damage. So Johnson & Johnson gets a warning for thrombosis in the cavernous venous and the transverse sinus of women primarily, but there's thrombosis elsewhere. There's been portal vein thrombotic events reported with Pfizer and Moderna, well described. We have vaccine-induced thrombocytopenic purpura, VITT, report. It has its own name now. And now the vaccine neurologic injuries are coming in, all the different cerebral, cerebellar, cortical blindness, ocular blindness, tinnitus, headaches. The FDA put a warning on Johnson & Johnson for Guillain-Barré syndrome. AstraZeneca's got a warning for Bell's palsy. I mean, you couldn't come up with a list of more horrible complications for a product that people are supposed to volunteer for or supposed to be forced into. I mean, these FDA warnings are massive. I mean, these are massive warnings. 13,000 people have died in these injuries, these untreatable injuries. I mean, it's astonishing. It's just absolutely frightening that someone would be forced into taking one of these vaccines.
But people discount this information, right? They discount.
Well, they do a couple of things, again, because we're off the rails now. There's just fraudulent stuff going on. So if you take myocarditis, if you take any complication and you divide it by the number of people vaccinated, you could declare this rare. It's rare. Well, listen, if you don't check everybody for it, you don't know if it's rare or not. Not everybody had EKGs and troponins to see if they have myocarditis. Not everybody, had assessment of thromboses, right? So you don't know it's rare at all. The rules of safety are to consider everything the tip of the iceberg until we know otherwise. It's the tip of the iceberg. The conservative thing, because we care about people, we consider it tip of the iceberg. Right? We would never dismiss it as being rare.
Peter, the question I get asked a lot, and because people find themselves in trying to figure out, will they be able to feed their family or not? And so let's say they might not have an option. They don't feel they have an option not to take the vaccine. Do you have any recommendations in terms of treatment strategy to decrease risk along with that? Or if they've gotten the vaccine, would you treat them the same as almost with all the thrombotic issues?
There's a very important principle is, if someone said you have to jump out of a plane without a parachute to keep your job, you say, well, can I, should I take a paper bag? Should I take an umbrella? Should I, we should never accept a potentially fatal injection in order for employment reasons or education reasons or elsewhere. That's called moral hazard. So the moral hazard is saying, listen, we're going to go ahead and hand wave this one by. And yeah, we don't think this is safe. We've seen 13,000 Americans die, 500,000 injured. But for you, because you could lose your job, like half of America is going to lose their job. But for you, you should go ahead and take it, and we'll try to work our way around it. I just tell you, I just think that's a moral hazard. I don't think we can go there. We should just tell people, listen, now's the time for a lot of backbone. We got the most labor constrained markets that we've had in history. These hospitals can't afford to have 5 nurses walk off the job, let alone 500. And the bottom line is, this is the great American showdown. And since these vaccine mandates have come out, people haven't taken the vaccine. They're not taking it. The pilots are ready to walk. People are ready to walk out. And I think you're going to see these vaccine mandates crumble in the next few weeks. A lot of it's going to be because A, the vaccines don't work, and B, it's just people aren't going to take them. They've already. I think they've actually disenrolled a couple thousand students from University of Virginia, and the parents are probably going to sue to get their tuitions back. Duke University, which forced the vaccine on the kids, they've already had an outbreak of 300 kids before they even got started. They all got Delta spreading to each other. It's obvious the vaccine works. So there's just all the people forcing the vaccine are going to have egg on their face. And interesting, Cleveland Clinic not forcing the vaccine. Neither is University of Pittsburgh Medical Center, UPMC. They're a big operation. So
I have a cardiology to cardiologist question. But I had to admit a kid to the ICU.
You turn the light for the kitchen. Yeah.
Because day 2 after his second Pfizer vaccine, he came in with a heart rate in the high 20s, low 30s. Yep. What I've been seeing as I go to patients' homes is that I feel like their heart rates, even though not necessarily bradycardic, they're lower than I would expect for their level of illness. Have you seen and I was just wondering if we're having some of this inflammation involving the SA node.
Yeah.
And that is an early sign of a myocardial inflammation, because it just seems when I come in and see a patient who's as sick as they are, I don't expect them to have a heart rate of 60.
Yeah. Well, it's clear that that we see a whole array. I've been called young kids in their 20s with atrial fibrillation. We've seen sinus bradycardia. We've seen new bundle branch blocks. I haven't seen complete heart block yet. But we clearly, in the CDC had 600 cases in their universe back in June that they knew about, 200 where they had at least some data. And of the 200, 90% of the kids were hospitalized. That tells you that was severe. Very high troponins, EKG changes. About a quarter had left ventricular dysfunction on the echo, a quarter. So they had to go on heart failure drugs. I've got a few in my practice. I've reported them. The myocarditis, the thing that makes me really uncomfortable is not getting better. So now it's like a couple months into it, the troponin's not going down. There's still some subtle chest pain. The kids are trying to get back to school. It's really disconcerting.
And that's post-vaccine, correct?
Yes, that's
versus post-COVID, right? Because Kirk has seen both at Inpatient, right?
Right. So the post-COVID is interesting. So what we know there is people sick enough to be in the ICU, about half of them have an elevation in troponin. It's like ICU sickness, but they typically don't have the EKG changes, what have you. And there's been a few cases of young people with post-COVID myocarditis. I personally think I had it because I had chest pain for about 5 days afterwards. It's nothing like the vaccine myocarditis, nothing. And there's really another fraudulent paper in the New England Journal of Medicine that just came out that looked at COVID myocarditis, and they tried to divide the number of the people who got COVID, and then vaccine myocarditis, and they tried to divide by the universe who got the vaccine, and they come up with numbers. Oh, you're far more likely to get myocarditis with the COVID than you are the vaccine. And it was just a fraudulent paper. Of course not. You can't just divide by these big numbers without checking it. You know, the problem with dividing by the natural illness is that we know everybody's hospitalized gets troponin checked. So we actually know we're not checking all the kids for troponin after the vaccine. It's only when the mothers are really concerned do they bring the kids in, and we see the hearts being damaged.
Yeah, and most teenagers complain about fatigue and tiredness and everything else. So mothers go, "Oh, whatever, just stay in your room."
Yeah. Well, listen, in the registrational trial by Frank and colleagues, New England Journal of Medicine, Pfizer, kids age 12 to 15, 2,200 kids randomized. A third of the kids had to stay out of school the next couple of days with high fever, body aches, myalgias. The vaccine makes the kids really sick. I bet if they check troponins and EKGs, I bet the myocarditis rates are through the roof. So I think myocarditis is clearly tip of the iceberg. Again, another reason why you just can't give a free pass to this. You can't say, oh, for you, it's okay. You want to play sports, you can take the vaccine and just risk it. The moral hazard is too high. And as soon as we start telling people they can take the vaccine, now that we know all this, we're going to get burned with moral hazard. There's a lesser moral hazard to just have somebody get COVID and treat them early to get them through it than having a permanent injury from the vaccine.
That's a discussion I had with a reporter, because they kept really trying to push me. So, but why do you have such a problem with recommending it? I said, because I don't know. I don't have years. I also don't know. And it is better for me, especially for a child, for me to let them get COVID than for me to do something that harms them, right? That's the moral hazard you're talking about, right? And so they keep pushing, but why won't you recommend it? Right? Because we don't know. We have to be honest with what we know. And first, as a physician, I do no harm.
But not that do we not know, but we've been stonewalled. Don't forget, there was an October 22nd meeting by the FDA, NIH, CDC. They were going to have massive reporting to America on safety. They were going to use VSafe, VAERS, all the CMS, massive reporting. And then once the program rolled out, where's the safety report? We go the first week, second week, no safety report. We get to a month, no safety report. We're 8 months into it. They're overdue. They've actually never had a press briefing on overall vaccine safety. They've never had a press briefing on vaccine efficacy, nothing. They've stonewalled America on any data. How can we recommend any product where our agencies are stonewalling us on data, on anything? They basically say, listen, you go to VAERS and figure it out yourself. Listen, I've gone to VAERS. I don't like what I see. So unless they want to show me something else, it's a full stop. Listen, I didn't recommend it or not recommend it. 70% of my people got vaccinated. At about March, I started to feel uncomfortable. We had 1,600 cases of death by March, and the CDC put on their website, CDC and FDA doctors reviewed all the cases. None were related to the vaccine. Listen, I worked these panels. Do you know what it takes to get the death certificate? All the labs, the hospital, get 2 independent reviewers, adjudicate it, have a way of arbitrary. It takes months to do that. There's no way they reviewed 1,600 deaths. They just literally dismissed them. And that's malfeasance. That is malfeasance. And they did it again in June at 5,000 deaths. There's no way, there's no data safety monitoring board. There's no critical event panel. People like me and you, we should be on panels reviewing cases all the time to determine causality. So people got frustrated with this. McLachlan in London got the data. He just looked at the vignettes, got reviewers. 86% of the deaths have no other explanation. 50% they die within 48 hours of the shot. 80% die within a week. It's so tightly related to getting a shot. Seniors die. It's older people who die. The younger people get the injury syndromes, the neuro, myocardial, immunologic, and hematologic. I mean, it's just the moral hazard. And once the vaccine is in, there's a 100% chance they got the vaccine. When we have COVID, you know, there's a less than 1% chance people are ever going to get COVID. And if they get it, we can treat it. But with the vaccine, there's a 100% chance you're going to get it. So when you recommend the vaccine, it's 100% moral hazard on you. And I did a radio show with this guy, Hugh Hewitt, who didn't like me. He wanted to go after me. And he said about moral hazard, he goes, Dr. McCullough, if someone listens to this program and they don't take the vaccine and they get COVID and they die, that's on you. That's on your shoulders. That's your moral hazard. I said, listen, I'd rather have that and have early treatment and give my best shot treatment. But if they listen to you and they take the vaccine and they die, we can't stop that. That's your moral hazard. So anybody listening to this who's having a vaccine mandate, believe me, the people who are being mandated to the vaccine, they don't want it and they know it's not safe. That is the most primed population that exists right now. When they take the vaccine and they start having problems, who are they going to lever all their blame, their anger, their liability lawsuits against? It's going to be against the person mandating the vaccine.
So we're back to why we exist. Pono Coalition for Informed Consent. That's what we do, right? You do that when you interact with patients. Kirk does that when he interacts with patients. I do that when I interact with any patient. Risk, benefits, alternatives, and I have moral and legal liability for what I tell them. Right now, we have all these people stepping into that role, not knowing the individual patient, not able to give a risk, benefit, alternatives. They can't describe that, and having no moral or legal culpability, and saying you need to do this, right? So we've separated the informed consent from the procedure. And we have people who have no business recommending a medical procedure, recommending the medical procedure to patients. So
and not only that, but they don't even know what product. So I mentioned I had a conversation with someone at the Federal Reserve, I'll just say anonymously, someone incredibly powerful about financial markets in the world. And they were considering mandating the vaccine. I said, you must be somebody who appreciates data. I mean, in fact, I know you are. I know you are. I've seen you on CNBC. You care about data. We have 3 products. This mandate, I think, is about COVID-19. If you tell me otherwise, I think if it's about COVID-19, don't you want to mandate the best product? And don't you want to mandate the safest product? Or is it just any product? You know, this, and so anybody mandating a vaccine has to think about what are they mandating? We've got an abundance of vaccines. Americans have not taken vaccines for 3 months. They don't want them. So listen, you can have any choice you want. So if this is about COVID, wouldn't you want it? Wouldn't you want some transparency on what's the best vaccine? What's the safest vaccine? How to safely administer the vaccine? And he kind of thought about it. He's like, well, yeah, it's amazing. People are hazy. Things are coming in and out of vision. You know, they are medical products. They're not all the same. Moderna is a very different dose than Pfizer. J&J is a very different mechanism. No transparency. And
they're all new mechanisms that we've never.
There's no transparency. The FDA and CDC, which are the sponsors of the program, have given no differential report card on how the vaccines are doing. How can you mandate a product when there's been no report card on the product? How can you?
So I appreciate this. We've taken 2 hours of your time, and thank you. Let's finish with, I mean, we want people to know that early treatment is available. Let's finish with, I think it was on one of your slides, AAPS. I'm seeing questions come in. People want to know they're having trouble getting access to doctors, right?
Well, listen, what is happening is, and I just got 5 more patients during this webinar, they're not even trying their patients. They're not even trying their doctors. They're not even trying. They're not even trying. Patients need to pound their doctors, pound them, call the on-call. I'm going to tell my patient, call your doctor, pound them, demand early treatment, figure out where these monoclonal antibodies are and demand a monoclonal antibody infusion if you're a high-risk senior, and then demand the drugs. Demand the drugs. Doctor says, I don't treat COVID. Fine, make a referral. Refer me to somebody. Listen, I don't treat acute diverticulitis. Somebody call, I'm on call. I've got to make a decision. That's a doctor's job to actually make a referral. Failure to do that is called failure to treat. The doctors who are failing to treat COVID-19 are committing malpractice. If you can't treat it yourself, you are obligated to make a referral. And patients right now are they're giving up. They're just, honestly, I think myself and 500 doctors and you two, we are taking care of the entire country right now.
And so people can find those doctors. AAPS website.
AAPS keeps a list of the 500 heroes that are treating all the country, but you got to be patient. Look at me. I can't answer all these calls.
Yeah.
I can't. And I don't have a scope of practice that allows me to just willy-nilly meet somebody by texting and start prescribing drugs for them. I can't. They've got to be registered in my clinic. I've got to have a medical record. I can't practice outside the scope of my license. So patients have to start calling their doctors now and say, listen, what are you going to do when COVID comes knocking? Do you treat COVID-19? And if you don't, what's your referral pattern? I want doctors to start getting fried by their patients. If patients don't start showing some backbone here, we're going nowhere. Patients are acting like lambs. They're saying, listen, I'm going to lose my job. What vaccine do I have to take? Can you write me an excuse? My doctor, well, I don't even call my doctor. Can you take care of me? It's like as if COVID-19 patients are little lambs right now. They got to start showing some backbone. They've got to demand treatment. They've got to kick some butt. This is about Americans taking care of Americans right now. The medical community is gone. We got 1 million doctors right now. They might as well not even exist. They're gone. They've checked out. The only thing they care about is someone taking a vaccine.
I think what was important was the senator from Kentucky who said, you must resist. They cannot arrest all of us.
Yeah. And not everybody can lose their job.
Exactly.
Listen, I think this spring, some people are going to have a day or 2 week off. There was a recent pharmacist that was really panicking. He said, listen, I've had COVID before. I can't go again. They're trying to force the vaccine on me. They're going to make me mandate Kaiser, big operation, right? You got Kaiser out in Hawaii. I said, well, fill out the medical and religious exemptions. Fill them out. He filled them out and he submitted it. It was like 5 minutes later, he got an email back saying, your exemptions are rejected. And 5 minutes. And that was somebody on the other end of that email, some clerical person or whatever that just was told. And so he goes, well, what do I do? And I said, well, Liberty Counsel is one resource. Yeah. I mean, I am answering about 1,000 panic emails a day, just giving resources like go to the internet, look up these resources. And then the Liberty Counsel gives some instructions on what you're supposed to do. So he emailed back, he goes, is this the office that I go ahead and file a letter of intent for lawsuit on this? And then 5 minutes later, oh, we're pleased to tell you your exemptions are accepted. So I mean, the point is, this is a game of chicken, and the vaccines don't work. They're not safe. This is a game of chicken. America needs to have some backbone, stand up, and listen. The Novavax vaccine looks great, and if they feature that in the fourth quarter, different story. I don't think we're going to have the toxicity. There's none of the genetic stuff, no tissue damage. You're going to respond to a little bit of spike protein. I think 5 micrograms. I think everybody can get through it. If they can adjust Novavax to cover Delta or Lambda, we could be in business. I mean, I'm not anti-vax. If it has to be like a tetanus shot. Yeah. Listen, I got a tetanus shot. I'm all for it. All for it. But it's just these ones that, just like the first anything that comes out is typically not very good, and we don't go with it too long. And I tell you right now, Pfizer, Moderna, and J&J have got a really short time in medicinal history. They're going to be out of here. And we'll probably have safer products, but we ought to push safer products. We ought to be writing our legislators, FDA, where's Novavax? Why is it being delayed? What do you mean it's manufacturing delay? What is that? This is Operation Warp Speed. There's as much resources as humanly possible. You mean Novavax can't get an ounce of help in producing the vaccine? Really? I mean.
So we can let you go.